Good evening to all of you. I warmly welcome all those who are present at the moment for the clinical presentation done by the family medicine registrars. Today's speaker is Dr. Lakmal Rathnayake. He is a registrar in family medicine and is from the most senior batch of registrars we have at the moment. He is currently doing his clinical appointment at base hospital Panadura, and he has selected another interesting topic, which is diabetic neuropathy. As we know, diabetes is becoming more and more prevalent, and the knowledge on diabetes has been among physicians for thousands of years. But when it comes to diabetic neuropathy, the first literature on diabetic neuropathy appears only in around the 1798, 1800 that time. So it is relatively new. So what we know at present has been after that. So there's very a lot of knowledge that still needs to be discovered. And also, it's very, very important because this can lead to morbidity and a lot of economic burden on a country if we do not manage the situation properly. As family physicians, we have a huge role to play when it comes to managing diabetic neuropathy. So it is a timely discussion. It's an important discussion. So I invite Dr. Lakmal to proceed with the presentation. Usually these sessions are chaired by our president, Dr. Malkanthi Galhena. At the moment, she's attending an urgent matter. She said she will try to join in where his time permits. Until then, we will start and proceed. Lakmal, it's over to you.
Thank you, madam. Good evening, all the colleagues who are joining today for the presentation. And first of all, I would like to thank my trainer, Dr. Malkanthi Galhena, consultant family physician, and Dr. Fatima Attas, acting consultant family physician at base hospital Panadura. So I think you can hear me, no? Well?
Yes, you're very clear.
All right. Okay. So I have selected, it's not moving. Yeah. Prabhat, it's not moving.
Can you share again?
Yeah. All right. Okay. First of all, I have selected some two MCQs. Uh, uh, First one is the just to get an idea about the diabetic neuropathy. First one is the primary goal of diabetic neuropathy treatment is A is completely reverse the nerve damage. B, manage symptoms and prevent further damage. C, improve circulation in the affected area. D is perform surgery on the affected nerves. So just go through the MCQ and just, if you know the answer, you can send the answer to the chat box. And we will discuss it at the end of the presentation. Second one is, which of the following medication is not typically used for pain associated with diabetic neuropathy? A is antidepressants like duloxetine. B is anticonvulsants. Example is gabapentin. C is opioid. Example morphine. And the D is topical pain relievers. Example is capsaicin cream. So you just go through the two MCQs, and if you know the answer, you can send to the chat box while I'm presenting, and we will discuss it at the end of presentation. So in my presentation, mainly I will discuss the case history, the patient who attended to the base hospital Panadura Family Medicine Clinic. So after that, I will just briefly discuss about the risk factors responsible for the diabetic neuropathy and the little bit about the pathophysiology of diabetic neuropathy and the classification of diabetic neuropathy and the major types of diabetic neuropathy and the investigations that we have to do uh, in diabetic neuropathy patients. So we are discussing that as well. So at the end, we will discuss the management options available and what are the new options we have to manage the diabetic neuropathy. So these are the outline of my presentation. So first, I will do I will just summarize my case presentation. Uh, yes. Uh, this is a Mr. X is a 63-year-old patient with diabetic hypertension, dyslipidemia, and CKD stage 3B, and the right-sided ischemic stroke 5 years back. Actually, he came to the our clinic uh, with the difficulty in walking for 3 weeks. That is his main complaint when he's attend to the clinic. Mainly difficulty in lift off the right foot from the floor. That is what his main complaint. Uh, but previously also he had right-sided ischemic stroke 5 years back, but it was settled completely. But this again a new thing that he come with the difficulty in walking in the because of he cannot lift up the right foot from the floor. And it started slowly 3 weeks back, and it's gradually progressive up to now during last 3 weeks. And he's having bilateral foot and hand numbness during last 5 years, and it is also progressive. Sorry about that, this one is not moving. So And he's not complaining any calf pain when he's walking, and but he's complaining mild chest pain and mild SOB on exertion during last 1 year. And he's having the symptoms of chronic kidney disease because he's already diagnosed to have CKD stage 3B, and because of that he's having the proteinuria and the bilateral ankle swelling during last 1 year. And he's complaining reduced vision, even though he has underwent the bilateral cataract surgery 2 years back. Still he's complaining the reduced vision. uh, and he's having the on and off faintishness, sweating, especially in the morning. Uh, so that is more suggestive of hypoglycemic symptoms. And he does not have any osmotic symptoms or any symptoms or signs, any symptoms suggestive of balanitis because of high blood sugar. So he doesn't have that thing. And he's getting faintishness, especially in the standing position. When he's getting up from the lying down position, he's getting the fainting attacks and darkening. And he's having the on and off diarrhea and constipation during last 6 months. At the same time, he's having the urinary incontinence, urgency, and poor stream during last 3 years. And he's complaining erectile dysfunctions also. But he doesn't have any back pain, loss of weight, loss of appetite now. And in past medical history, as I have mentioned previously, he is diagnosed to have diabetic hypertension, dyslipidemia during last 15 years. But the thing is, during these 15 years, he has a very poor glycemic control and blood pressure control without any proper follow-up. And he had a right-sided ischemic stroke 6 years back, but he recovered completely from that. And he diagnosed to have CKD stage 3B 2 years back. Even that also he has not followed up regularly. And same time he is having the lower urinary tract symptoms like uh, poor stream and hesitancy, and he's taking tamsulosin daily. He underwent the bilateral cataract surgery 4 years back. So other than that, he has not underwent any surgery. And he's having the diabetic and family history of CKD. Family history of diabetic and CKD because his father also diagnosed as CKD and he died. He does not have any allergies. Psychological history, he's having the poor sleep, appetite, and lack of energy and interest, suggestive of moderate depression. But he does not have any suicidal ideas or any suicidal attempts. But he's worried about this walking difficulty because of this. The 3 weeks he's having the walking difficulty. Because of that, he's a little bit worried. The other main thing that he's worried is that he's having his wife and two daughters who are married already, but they have cornered him, though they are not looking after him. Like because of that, he's worried about that also, uh, regarding that family member's attitude. And in social history, actually, he lives with a wife. There were two daughters. They were married and separated. They were not live with them. Uh, these days, they are facing a lot of economical hardships. But previously, he has worked in some private company and he has a good economical status. But now he's facing a lot of problems. Uh, He's currently not smoking and not taking alcohol, but he has used to take alcohol and do the smoking 3 years back. During 30 years, he has taken alcohol and smoking. He's doing the gardening as a hobby. On examination, he's in low mood and very poor self-care. His BMI is 29. He's mildly pale and he's having the bilateral ankle swelling, but he's not distinct. Thyroid gland is normal, but his skin is dry. All over the skin is dry. And cardiovascular system, his pulse rate is 90. blood pressure in line in blood pressure is sorry, this is blood pressure uh, in line down position. It is 130/80, and in lying down position it's 160/90, and in upright position is 138. Is just mistake. And no any heart sounds, and respiratory and abdomen is normal, and the central nervous system, cranial nerves normal, and pupil equally reacted to the light, and bilateral fundi, they were diabetic retinopathy, and bilateral upper limb pain, temperature, uh, bilateral upper limb pain, temperature, and reflexes normal. Sensory, there is a glove and stocking type sensory loss in bilateral hands. Bilateral upper limb lost joint position and vibration also, and bilateral radial and also pulses were felt. Lower limb examination, hip flexion, extension, abduction, adduction, all normal with normal power. Bilateral knee flexion and extension normal, but bilateral uh, plantar flexion and eversion also normal in power 5. But right-sided dorsiflexion and inversion is less power. It's 3 out of 5. And left dorsiflexion and inversion, left side is normal. Bilateral ankle jerks were reduced, but bilateral lower limb, other reflexes normal. In lower limbs, there's the symmetrical glove and stocking type sensory loss in bilateral feet up to the middle of the legs. So pain, temperature, touch and pressure, all things lost. And the bilateral lower limb, loss of joint position and vibration sense as well. And the bilateral molybdenum test is 0 out of 10. And left, in left foot there is an ulcer, and it is not healthy as well. And but no, there was no any Charcot joints or callosities. Bilateral posterior tibial and dorsal pedis pulse were felt. Differential diagnosis, actually, after considering previous comorbidities, the present problem made differential diagnosis. One is the another attack of cerebrovascular accident, and the second one is the diabetic mononeuropathy, and the third one is the lumbar radiculopathy. So these are the we have taken as differential diagnosis for this current presentation. And the problems we have identified, the main problem is the poorly controlled diabetic hypertension, hyperlipidemia, causing multiple macro and microvascular complications with multimorbidity. And this current issue is the difficulty in walking. Mainly, we think that it is due to diabetic mononeuropathy because it is progressive. It is not very acute also. It is progressive, and it involves only very focus area, only foot drop. Like he can't dorsiflexion of the right foot. So that involves only the very focal area. So that is more likely to be diabetic mononeuropathy when we are considering, because we are considering the onset and progression and the involved region. And his other problem at the moment is the unhealthy diabetic wound, and he's in the moderate depression as well now. And the thing is, he's diagnosed as CKD stage 3B, and he's having the past history of cerebrovascular accident. And we are worried that whether he is in the angina because he is complaining external chest pain during last 1 year. And he's also having the diabetic retinopathy and diabetic nephropathy as well. And the diabetic polyneuropathy and autonomic neuropathy as well, because a lot of history suggestive of diabetic autoneuropathy as well. And is hypertension and dyslipidemia. These are the main problems that we have identified on this patient. So after first encounter, he came in 1 week time with these investigations. So fasting blood sugar is 78. Uh, uh, that fasting blood sugar is on first visit. So second week he came with serum creatine 2.26, eGFR is 31, total cholesterol is 153 with LDL 95, urine full report is normal, and the ECG there were some T inversion in the lateral leads. So we think it is due to strain pattern or possible ischemia also possible. And the AST/ALT is normal. And we are waiting his full blood count, serum electrolyte, 2D echo, and nerve conduction studies and HbA1c. We haven't received yet. So the treatment that we have prescribed, so initially we have done the very comprehensive care to this patient, and we have addressed his physical, social, psychological issues, and individualized family and community management, and mainly family medicine oriented, curative and preventive treatment as well. Mainly, he need a secondary prevention to reduce the complications. And we have done the counseling, especially regarding the importance of continuing treatment and regular follow-up, because he has lost last 15 years his regular follow-up continuity of treatment. And we have done the health education about the diet, exercise, and the importance of continuing treatment and follow-up. So these are the treatment we have started, because we don't know what are the drugs he's on, because he has taken on and off drugs. So what we have prescribed is because he is having the past history of CVA, and currently we suspect the angina. We have started him on aspirin and the atorvastatin 40 and glycoside 40 milligrams started. He's on 80, but we have reduced up 40 because he's having some hypoglycemic symptoms in the morning. And we have started him on duloxetine 20 milligram noctate to address his depression and the peripheral neuropathy, both to address. And the linagliptin and empagliflozin also we have started because he's having the CKD stage 3B. EGFR is 31, so we have not gone to the metformin. So renal friendly drugs, linagliptin we have started, and the empagliflozin we have started. And the losartan 25 milligram BD and bisoprolol 2.5 milligram BD. And we have planned to do a neurology referral to do the neoconduction studies and assess his neurological functions, and the nephrology referral to follow up and management of CKD part. And then we have arranged eye referral to address the diabetic retinopathy, and cardiology referral for the most probably is having the angina. Because of that, we want to assess his cardiovascular risk and 2D echo and things. So that also we have arranged. So we are coordinating we have done the referrals, and we are coordinating all the other units, and we manage the patient and follow up in family medicine clinic, best hospital, Panadu. So that is my main case history, examination and problems I have identified. So any problems at the moment before we go into the description, anything you want to ask regarding the history and examination?
And Dr. Lakmal, Hasara here.
Yes.
This patient in the examination, what about his reflexes? Were the reflexes
Yes,
like upper motor neuron type or lower motor neuron type?
no, his ankle reflex, both bilateral ankle reflex were reduced,
Okay.
but it was not exaggerated. But other knee reflexes normal, bilateral lower limbs. Yes.
Okay.
Upper limb reflexes normal anyway.
Normal. And one more thing, the reason to be on beta blocker, is it he's having orthostatic hypotension, no? In that case, won't the beta blocker aggravate the orthostatic hypotension? I'm not too sure
Yes,
whether it
possible.
can cause.
But we suspect that he's having the angina because he's giving the chest pain
Okay,
on
because
exertion.
it's
So that's why we thought to start a small dose of the
okay.
prologue. Yes.
He had exertion and
What was
angina.
the reason for the tachycardia he had? Lakmal, you said pulse rate was around 90.
90, yes. Actually, we thought it's a autonomic neuropathy because he's in resting tachycardia. Because that we think that it is due to autonomic neuropathy, and I think that part also we have considered when we are starting the bisoprolol.
Did you start beta blocker yourself, or was it on the previous drug list, or what happened? Did you add it during this visit?
No, he's on bisoprolol previously. Yes, we have.
My guess is probably because he has a history of ischemic stroke. He
Yes,
probably would have had a echo at some point, no? And
yes,
maybe the cardiology referral was done for the medical management opinion as well, while he was being treated for the CVA.
yes.
So it's
But he
possible that
didn't.
they added it, isn't it?
Yes, but he didn't bring any records of the previous that stroke. He didn't have that.
All right. So, but he had some documentation that he was on a beta blocker previously. Is that what you're
Yes,
saying?
yes,
Ah,
yes. He had
okay.
some.
Right.
Then, so we will go for the little bit of description. So
Lakmal, may I
mainly,
come in here?
yes,
Lakmal,
yes,
that patient had, you mentioned that had peripheral neuropathy, I mean, love and spasm type neuropathy.
yes,
In that case, do you need to do the monofilament test? I mean, it has been
yes. Actually, I have
evolved
presented monofilament test I have done, and it was bilateral. All the 10 points are
negative.
zero. He couldn't fill.
Actually, I want to know, is it, it is a part of the examination? Should you perform that because of there is peripheral neuropathy? I mean, the glove and stocking type neuropathy. Is it should you do that thing?
I think
Monofilament
yes,
test.
yes, we have to do it, no?
Yes. The
Because there is glove and stocking type neuropathy.
neurophysiological testing is one part of diagnosing diabetic neuropathy apart from the history and examination. So you need to do it, and as uh, like it is the most easiest component of the neurophysiological examination we have in our clinic. So we can start with that, but there are other modalities. Since it's
Yes,
zero scope for this person, he is at very high risk for getting
yes,
foot ulcers and so on. So maybe you will have to do other tests as well.
yes.
Right? Okay. But you have to do at least one neurophysiological assessment to diagnose diabetic neuropathy apart from history and examination,
Yes,
the other examination.
right. Now I will go into the little bit of explanation about the diabetic neuropathy. So the mainly definition, actually, I have selected a very simple definition. There were some high-fi definitions, but simple definition is that the presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetic after the exclusion of all other causes. So it's very simple. When the presence of the symptoms or signs of peripheral nerve dysfunction with the patient is diabetic after excluding all the other possible causes. So that is called diabetic neuropathy, right? And the prevalence is actually it's 66% in type 1 diabetic, and it is 59 in type 2 diabetic. So when we are considering all together, around 60% of patients with diabetic having the diabetic neuropathy. And if the patient is having diabetic for more than 10 years, what they say is around 100% of, that is almost all people with diabetic more than 10 years have at some level of diabetic neuropathy. And what type of diabetic neuropathy they have.
Can I add something,
Yes.
Lakmal? Here, what you're saying is correct. The prevalence of diabetic neuropathy in type 1 and type 2 are almost similar. But when you consider the incidence, diabetic neuropathy in type 2 is very much higher than type 1. So that is related to the age of when this type 1 and type 2 occurs, and then also the pathophysiology. The other thing we need to remember is that at presentation, the first presentation of diabetes, about 8 to 10% of people can present with diabetic neuropathy features. So from the first encounter itself, we need to screen for diabetic neuropathy, at least do a monofilament test at the first comprehensive examination. So
Yes, the thing
remember
is
that.
that, yes, even in the pre-diabetic stage, the nerve damage process will start already. So because of that, especially in the type 2 diabetic, what they have recommended is type 2 diabetic, we have to do the monofilament the screening, diabetic foot screening, neuropathy screening at the time of diagnosis in type 2 diabetic. But in type 1 diabetic, what they say is it has to be started after diagnosis is 5 years, then annually. In type 2, at the time of diagnosis and annually. And actually in diabetic, you can see the slides, no? Hello?
Yes, we can see.
Alright. Yeah, actually in diabetic, when we consider the chronic complications of diabetic, so the commonest complications is diabetic neuropathy, right? But the thing is, the attention that we have given to the diabetic neuropathy is less compared to the retinopathy, nephropathy, and other macrovascular complications. So we are doing more eye screening, and if even patients, if they reduce their vision, they are more concerned. If they develop ankle swelling or if they develop uh, proteurethria, they are more concerned. But the neuropathy thing is, they won't feel anything. Even after they will develop the neuropathy 2 to 3 years after developing neuropathy also, they don't know whether they have a neuropathy. So that is the problem with diabetic neuropathy. So we diagnose most of the diabetic neuropathy in the latter part of the disease, right? So, but the commonest complications is diabetic neuropathy. It is around 60% of total diabetic patients. The risk factors, if you have considered the risk factors for the diabetic neuropathy, so we have divided them as a modifiable risk factors and unmodifiable risk factors. The modifiable risk factors, and the one of the most important risk factor is the glycemic control, right? That is one of the important, and we should have to address that issue, that poor glycemic control is the major risk factor for the developing the diabetic neuropathy. And the other modifiable risk factors are obesity and the alcohol consumption. So alcohol consumption itself can cause the peripheral neuropathy. But if the patients with diabetic who are taking the alcohol, they are more prone to have a diabetic neuropathy other than the peripheral neuropathy due to alcohol. And the hypertension also a risk factor, modifiable risk factor for the diabetic neuropathy, and the smoking and the hypertriglyceridemia also a risk factor to develop the diabetic neuropathy. And the non-modifiable risk factors are age, when we are old age, so the developing the neuropathy is more, because even without diabetic, people can have a peripheral neuropathy when they are become old. And the height is also, if the height is more, they have a more prone to get the diabetic neuropathy because their nerve length of the nerve fibers will be high. That is mainly dependent on the length of the nerve fibers. That's why that lower limbs are more affected than the upper limbs. So if we are high, more high, the height is high, then they are more prone to have a diabetic neuropathy. And if they have a family history of neuropathic disease, they are more prone to have a diabetic neuropathy. And any other thing is the duration of diabetes. As I have mentioned previously, so if the diabetic is more than 10 years, so almost all have a diabetic neuropathy. And if they have an apogenotype, gene type, so that those people also vulnerable to have a diabetic nephropathy compared to the normal people. And the aldose reductase gene hyperactivity and the angiotensin converting enzyme genotype also, these people are also more prone to have a diabetic neuropathy compared to the normal people. And the pathophysiology, so I will not go into more detail, but diabetic neuropathy pathophysiology is actually it's mainly due to two reasons. One is the microvascular changes, and it will microvascular changes that will reduce the blood supplies to the nerve. So the nerve perfusion also less, then nerve becomes ischemic and nerve damage will occur. So after that, diabetic neuropathy can have. The other main theories that they have developed is the metabolic changes. So metabolic changes due to hyperglycemia or maybe triglyceridemia or insulin resistance. So they have explained so many pathways like polyol pathway, hexosamine, PKCAG. So there are a lot of micromolecular level they have described. But anyway, mainly the oxidative stress. So that will reproduce the free radicals, and from the free radicals, they that free radicals will damage the nerves. So that is also one way of oxidative pathway of nerve damage. The other thing is inflammatory pathway and the mitochondrial dysfunctional pathways. So all these pathways they have described as a pathophysiology of diabetic neuropathy, but still there were some arguments and still there's some research were going on. So still not 100% confirmed. These are very gray area still, as Dr. Fasana mentioned previously. So it's still in the discussion. And the classification of diabetic neuropathy. So here actually there were so many classifications, but this is one of the simple classification of diabetic neuropathy. So the mainly they have classified into symmetrical and asymmetrical neuropathy. So symmetrical neuropathy or the symmetrical or the diffuse type of neuropathy, there were so many types, minor types, but mainly we are talking about the diabetic polyneuropathy, right? Diabetic sensory polyneuropathy is the commonest type of diabetic neuropathy, right? The diabetic sensory polyneuropathy. So other thing is symmetrical diffuse type is the diabetic autonomic neuropathy. So those are the main two types that we are going to discuss today, but there were some minor types. Hypoglycemia can cause diabetic neuropathy. Even insulin can cause diabetic neuropathy. So some inflammatory changes can cause. So there were so many minor categories, but the main type is the diabetic sensory polyneuropathy. So that will responsible for the most of the diabetic neuropathy and the diabetic autonomic neuropathy. And the other thing is the asymmetrical diabetic neuropathy. Asymmetrical diabetic neuropathy, so that they will take it as a mononeuropathy. Mononeuropathy is one thing for the asymmetrical diabetic neuropathy, and the cranial neuropathy. Actual cranial neuropathy also a part of mononeuropathy. And the other thing is the diabetic radiculopathy or diabetoplexopathy. So if the multiple nerve roots were affected or the plexus affected, that we call plexopathy. Or even one root is affected, they will say radiculopathy. So likewise, they have classified asymmetrical into so many categories. So I think At our level, this will be more than enough if we can remember this classification. And the main type is as I have mentioned previously, the chronic sensory motor symmetrical diabetic neuropathy. This is the commonest type. This will responsible by the 75% of the diabetic neuropathy. And this type is mainly sensory predominant, and it is having the glove and stocking type sensory distribution. Motor part involving is very much less. So minor amount of the distal muscles or lower extremities, and it's mainly length dependent, as I have mentioned previously. So it's length dependent. That means our lower limbs affected more compared to the upper limbs because lower limbs are more lengthy neurofibers are there. And the symptoms of symmetrical diabetic polyneuropathy symptoms. So there were main symptoms type. Actually, one type is the what happened is their foot is numb and they won't feel anything at the initial stage. Even 2 to 3 years till that they don't know whether they have a diabetic neuropathy. They don't feel anything. The risk is that, so because of they don't feel anything, so their foot is in the high risk because they can have a diabetic ulcers, they can develop the diabetic ulcers, and later they can develop, they will feel like even though they are walking on the hard surface, they will feel that they are walking on the cotton like. So that is one type of presentation, that is they won't feel anything, that is just a numbness of the foot. But the other main complaint type is some patients are complaining sharp shooting or stabbing type pain, especially in the night. So that is also one type of diabetic neuropathy involving symmetrical sensory diabetic polyneuropathy, right? So they will feel the very shooting type, very severe pain, especially in the night. And some patients are complaining dull, constant, or more in just diffuse pain on the bilateral lower limbs and the foot. And some patients are complaining tingling, pin and needle type tingling sensation in the foot. Uh, and some patients feel like hot and cold sensation. So what they feel is they feel the water under the foot, but they always check that whether there is any water or something in the foot. So that is because of mainly affecting nerve fibers, their function is disoriented. So the patient feel like hot or cold water sensation. So allodynia is so even we have given the very small stimulant, so they feel very severe pain. So that is called allodynia. That is also one symptom of diabetic neuropathy. The signs, especially in symmetrical diabetic sensory polyneuropathy signs, uh, distal muscle weakness is uncommon because this mainly responsible, this part is sensory is affecting. So the muscle involvement is very much less, but it can involve the muscles as well. So that's why we have seen that if they have involved the motor part, so they will have their joints and their muscles is weak. And so they will develop the ankle reflex can absent because of loss of muscle functions. And they will lose the sensory, mainly as I mentioned, it's mainly length dependent distribution. And the other thing is they will lose the vibration uh, sense because that is the first sensory modality that we lost during the symmetrical bilateral diabetic polyneuropathy, the vibration. As the sensory loss extent, it's like glove and stocking type sensory loss. There are two types of fibers involved for the diabetic polyneuropathy. One is the large fiber neuropathy. Large fiber neuropathy is actually that, as I mentioned in the first symptom, is the painless paresthesia beginning at the toes and feet. So they won't feel, just like a numbness. So these fibers are mainly responsible for the touch and pressure, and the vibration and joint position sense also they will carry through these large fibers, and that they will carry some motor fibers as well, so that their reflexes also become less. And the small fiber neuropathy, so they will feel that small fibers are carry out mainly the pain, responsible for the pain and temperature. So what they feel is that they feel if their small fibers are involved, they will feel the very severe pain and the burning type of pain in the night especially. So that's why the one part of people are complaining numbness in the foot, others are complaining the very severe burning type, shooting type pain. So if they are more prominently involved small fibers, they complain in the shooting type pain. If they are involved in the more large fibers, they complain the numbness of the foot. But here there was no very most of the time we see that mixed type as well. So the commonest is the mixed type. So both small and large fibers are mixed type. So in that case, they will feel the numbness and the pain and the motor involvement and the autonomic involvement as well. So this bilateral lower limbs, while they have a bilateral symmetrical polyneuropathy, they can have autonomic neuropathy as well. So they will have less sweating in that area, also because of polyneuropathy. And so after that, we'll develop the first type that we have discussed is the bilateral symmetrical polyneuropathy. So mainly that is two type. One is the numbness that involve in the mainly large fibers. So they will feel complain the numbness. So other main type is that they will complain the shooting type pain that will involve mainly the small fibers. So mixed type also there. And the autonomic neuropathy can have, it is also diffuse type. It involves the cardiovascular system, gastrointestinal, urogenital, respiratory, people. So many systems are involved. And the one of the major thing is major symptom is the because of diabetic autonomic neuropathy. So they will usually what happen if the patient is feeling drop into the hypoglycemia, so they will feel the autonomic symptoms, especially they will feel the palpitation, sweating, and they will feel the hungry. All those things patient feel because of the autonomic system. If the patient is having the autonomic neuropathy, what happened was they won't feel any of these things. So they will drop their blood sugar 60, 50, 40, 30, but they won't feel any autonomic symptoms. So until the patient is fainted and go into the hypoglycemic coma and develop the seizure, they won't feel any symptoms of hypoglycemia if the patient has developed the autonomic neuropathy. So that is called hypoglycemic unawareness. So in this type of patient, what we have to do is we advise them to maintain the blood sugar in safe level, around 130 fasting blood sugar or 140, maximum 150. We advise them to maintain the fasting blood sugar or HbA1c more than 7. We advise them to maintain because of the hypoglycemic awareness. The other thing we can do is that now we have a continuous blood glucose monitoring system. So what they have addressed is if the patient is having autonomic neuropathy, better to do a continuous glucose monitoring. So if they are going to do that, so what happens is the patient has gone to the hypoglycemia, they will know sometimes alarm, sometimes from the SMS, they will inform that patient is going to the hypoglycemia, even though they are unaware about the hypoglycemia. The other thing is other system that affect due to the autonomic neuropathy is the cardiovascular system. So what happens is the resting heart rate is high because that autonomic neuropathy will lose the vagal inhibition. Because of that, the resting heart rate is high. Other thing, what happened is their cardiac function variability, their heart rate variability also lost because the sympathetic system will increase the heart rate, parasympathetic will decrease the heart rate. Because of the autonomic neuropathy, that heart rate variability is lost. So because of that, they feel even with the physiological function when when he is walking, running. So they won't increase their heart rate and does not increase the stroke volume. So they will feel the faintishness, chest pain because of this autonomic neuropathy. Other thing they can develop is the silent myocardial infarction because they lose their pain sensation because they lose their autonomic neuropathy. So they will develop the myocardial infarction even without a pain. Other thing is orthostatic hypotension because if the normal person is getting up from the lying down position, what happens is their vascular system is contraction and their blood will pump into the heart. But if the autonomic system is fail, their blood is full in the lower limb, so that will lead to orthostatic hypotension or postural hypotension. So what we can do is, if the patient is having the postural hypotension, we can advise them to wear some stockings, like graduated stocking. We can advise them, or otherwise we can ask them to take more salt or take the more fluid to expand the plasma volume. Even that is not responding, so we can give them a plasma expanders. We can treat with plasma expanders like fludrocortisone and things. And in the gastrointestinal system, what they have is the top to bottom from mouth to anus that will reduce the gastric motility. So because of that, if the patient is developed reduced esophageal motility, so they will feel the nausea and regurgitation, vomiting like feeling. And if they reduce the gastric motility, so they will lose their gastric emptying. So gastric emptying will be delayed. Because of that, patient feel the fullness of the abdomen, of gastric fullness, vomiting and regurgitation. And if they lost their functions, morbidity in the small and large intestine, they will develop the diarrhea and constipation. So these are the problems they can have. So if they develop the gastroparesis, so we can treat with domperidone or maxalone, or we can advise patient to take the frequent small meals to prevent the regurgitation. So these are the advices we can give to prevent these problems. So other systems can affect is the genitourinary system. Patient will develop the erectile dysfunction. That is very common with autonomic neuropathy. And the impaired bladder sensation. So even though bladder is full, patient won't feel the bladder is full. So more and more bladder volume will increase. So after that, patient will develop the incontinence. So overflow incontinence will be developed after developing the autonomic neuropathy in the neurogenic bladder. So the other thing they can develop is the retrograde ejaculation. They will develop because loss of autonomic neuropathy. So for the erectile dysfunctions, we can treat with some sildenafil or some prosthesis. And the bladder sensation also we can treat with some, we can train them a bladder training and things we can do. And the other pseudomotor functions is mainly, so that will affect the sweating, sweat glands. So that will reduce the setting of it will differ. The one part mainly face will have a setting, so other parts of the body will not have a setting. So likewise, there is a difference in the some parts of the body setting will be different, and they will develop the gustatory setting as well. While if they are taking the meal, they will develop the setting in the face and upper part of the body, but not in the other part of the body. So that is, there is a discrepancy in the sweating of the body. And the other thing, they can develop the sleep apnea. If they, while they are sleeping, they will lose their autonomic function in the smooth muscle, so they can develop sleep apnea and grunting things. And the pupillary function, so they won't react, their pupils won't react to the light properly. So if the patient develop autonomic neuropathy when they are driving, so that will be difficult even in the night. So with the light, so their pupils won't react properly. So because of that, they will have a problems and accident while they are driving and other problems. So that is autonomic neuropathy. So after that, we will go into the discuss about the mononeuropathy. Mononeuropathy is it's a dysfunction of the one nerve. So it can happen in two ways. One is the nerve entrapment, other one is the nerve infarction due to the microvascular problem. So the nerve entrapment is the nerve is compressed. That means in the median nerve will affect due to carpal tunnel syndrome. Thing is the carpal tunnel syndrome is more in the diabetic patients. So that is called entrapment neuropathy. And the ulnar nerve damage at the elbow. So that is more common in diabetic patients. So the Bell's palsy is more common in diabetic patients because it compresses the facial nerve inside the ear canal. So that is called entrapment nerve damage. The other thing is the infarction due to microvascular changes. So if it is happening due to the infarction, it is a more sudden onset mononeuropathy. If it is happened due to the entrapment, it is a very gradual nerve impairment. Right? So it can affect mainly the median nerve, ulnar nerve, fibular nerve can be compressed at the head of the fibula, and the nerve entrapment and infarction is the main two methods of getting mononeuropathy in diabetic patients. Other thing is the patient can involve more than one nerve. So one side he can involve the median nerve, other side he can involve the ulnar nerve and the oculomotor nerve as well. So if the patient is involving the multiple nerve at the same time, that is not the polyneuropathy. That is called mononeuropathy with multiple involvement. That is called mononeuritis multiplex. So multiple nerves are involved. That is mononeuritis multiplex, right? And the other things, this truncal radiculopathy, that is not very common, but just I will explain that radiculopathy is that will involve the one nerve root, mainly the thoracic and lumbar nerve roots can involve due to diabetic. So patient will come with either some part of the chest pain or abdominal wall pain or some muscle weakness in the abdominal wall, so they can develop the pseudo hernia. So things like that is happening due to the diabetic radiculopathy. That will involve the one nerve root. So we can confirm that from the EMG or nerve conduction studies. So that will not give any specific treatment, but most of the patients will inform in few months. Other thing is the plexopathy. Plexopathy means multiple nerve roots are involved. So that can be due to lumbar plexus can be involved, even cervical plexus can be involved. So that is multiple nerve roots are involved. And the patient will develop pain, sciatica-like pain. So the pain radiates through the lower limb because it's involved the multiple nerve roots. And patient will develop the pain. And they will have a depressed or absent knee jerk because it affects the whole plexus. So that is called plexopathy due to diabetic neuropathy. And the cranial nerve involvement, that is also one type of mononeuropathy. So commonest is the third nerve, oculomotor nerve involvement. So other cranial nerves involvement possible is the fourth nerve, sixth nerve, and the seventh nerve. Facial, abducent, trochlear, and the oculomotor nerves are the commonest nerves can be involved in the cranial nerves, but the commonest one is third nerve. The main thing is what happened in the oculomotor nerve. So patient will develop the ptosis because it will that will paralyze the levator palmar superioris and the other extraocular muscles. So patient will have a diplopia and the ptosis, but the when the oculomotor nerve is affected due to the diabetic, so what happened? The peripheral part of the nerves will be preserved because of the because of their collateral circulation. So because of that, their pupillary functions will be preserved while the other oculomotor function is gone. Right? The Bell's palsy also seventh nerve palsy due to diabetic neuropathy. So Bell's palsy is more common in diabetic patients because that is also one type of diabetic mononeuropathy involving cranial nerves. So these are the types of diabetic neuropathy. So I will rush because the time has passed. So what the main thing, if you have diagnosed the patient with diabetic neuropathy, the main thing is whether it is a diabetic neuropathy or neuropathy in a diabetic patient. So that means we have to exclude the other possible causes for the neuropathy before come to the diagnosis of diabetic neuropathy. So these are the features that is more concerned. We are more concerned about whether this neuropathy is not the diabetic neuropathy, it is something else. So that is, these features are the things that if the neuropathy is very rapidly progressive, because diabetic neuropathy is very slow progressive, but if the neuropathy is rapidly progressive, that is more suggestive of uh, other neuropathy than the diabetic neuropathy. The other thing is if the motor involvement is prominent or the more cranial nerve involvement is more. So then we have to think about other possible causes of neuropathy other than the diabetic. But diabetic neuropathy also can have, but we have to think about other possible causes. And as we have mentioned, the disproportionate large fiber abnormalities. If the large fibers are involving more, so then again we are thinking about other possible neuropathies other than the diabetic. And the involvement of the whole lower limb without involving the region, as this patient is developed only the foot drop. But if the patient is involved in the whole lower limb, so we have to think about something else other than the diabetic neuropathy. And the other thing is if they have developed the involving the hand more than the lower limbs, or upper limbs are involving more than the lower limbs, again we have to think about other possible causes. Other thing is we have to think about if the patient is having family history of neuropathy, we have to think about other possible causes. And the asymmetrical diabetic neuropathy, we have to think about other possible causes other than diabetes. And the selective small fiber involvement, and the patient is having the developed the hamartos and pescators. That means more involved in the motor part. If the motor nerves are more involved, patient will develop the hamartos because their ligaments and muscles will be weak. Because of that, their foot will be uh, uh, deformed and their pressure points will be changed. So if that case, that time we have to think about something else. And the investigations like this in secondary care, if they have a monoclonal gammopathy, if the CSF protein is more than 100 and the high ESR, rheumatoid factor 80 positive, we have to think about something else other than the diabetic. And the investigations recommend is the mainly uh, we have to think that to exclude the other possible causes. So we are not going to do whole list of investigation for each and every patient suspecting diabetic neuropathy. So what we have to do is that we have to assess the patient clinically. If we have suspect that any possible other causes is possible, then we have to do the investigations like nerve conduction studies, even liver function test, other possible B12 level, vitamin D levels, thyroid function. So all these things we can do if the patient is suggestive of those symptoms. But whatever the things the patient is having, we have to assess the blood glucose control. So the glucose control definitely we have to do, and we have to control the blood glucose tightly. Electrophysiological testing, actually we have to do the we are not going to do the each and every patient for electrophysiological testing. So there were some indication. If we have do the electrophysiological, we can confirm the diagnosis. Uh, our clinical diagnosis we can confirm. Other thing is we can identify the pattern or characteristic of diabetic neuropathy, and then we can monitor the progression or remission, and the detection of asymptomatic cases also possible if we have done the electrophysiological testing. And the electrophysical testing cannot specifically, it's not pathognomonic, it cannot confirm the diagnosis of diabetic neuropathy. So just a supportive diagnosis, our clinical diagnosis will support by the electrophysiological studies. And this is neuropathic disability score. So after that it's modified. So modified neuropathic disability score. So I am not going to explain. So what happened is they will give the 10 marks. So they will do the vibration and temperature pressure and the pinprick test. So they will give the marks according to this, and they will do the acrylic tendon reflexes as well. Out of 10, if they have, if the score is more, so they will have a more risk of developing foot amputation. So if the score is more than 6, they said there is a high risk of developing a foot amputation. So I will not go into much detail because of the time constraints. And the other things, other test we are doing is we all are familiar with this monofilament test. What we have to do is we are using the 10-gram pressure in the 10 points of the feet and the 9 points of the blunt aspect of the feet and one side in the dorsal aspect. So we check whether the patient is feeling sense, and we check their peripheral neuropathy and sensory. So after that, we use the tuning fork test as well. So we are using different sides. So mainly in the bony parts. It's a graduated. We do first do the at the tip of the thumb. So after that we do the in the malleolus. So likewise we are gradually going up to assess the vibration sense of the patient. So other thing is we are doing the biothesiometer. So this is also there's a probe that deliver the vibration sense. So what we do is we do increase the vibration parameter with the uh, with this machine. So we'll ask at what point where the patient will start to feel that. So that level we mark the voltage of that the vibration. So according to that value, we can decide whether the patient is having mild, moderate, severe diabetic neuropathy. But that value will be differ according to the machine and the method we are using. So that will depend on the method that we are using. So the management of diabetic neuropathy. So mainly, the first thing is that we have to exclude the other possible causes as I have mentioned previously. So other possible causes are so it may be some malignancy, it may be some metabolic causes, alcohol, some infection like HIV or syphilis, or other drugs is possible, especially chemotherapy and anti-TB drugs. And the other thing we have to do is that we have to support the support to food protection. So we have to explain to the patient, and uh, we have to advise them to prepare a good shoes and food protections. Also very important. But very most important thing is that we have to assess the blood glucose level and control the blood sugar level in optimal level. Not only the tight control, it should be variability also should be stable of the diabetic control. So the control of hyperglycemia is very important. So mainly the stability of the glycemic control, not only the normoglycemia, it's a variability of the blood sugar also should be limited. And the pharmacotherapy. So mainly there are a few types of the drugs we are using. So the tricyclic antidepressants are one main group that we are using. So many random control trials have supported for the using the tricyclic antidepressant for the diabetic neuropathy and neuropathic pains. Mainly the amitriptyline, imipramine, desipramine are the drugs that we are using. The main problem is the side effects. Patient feel drowsiness, lethargy. So we can't give higher doses, but uh, we can give the tricyclic. That will depend. The dose will be depend on the patient and the side effects. Other drugs is the SSRI we can use, mainly the paroxetine we can use, but the fluoxetine does not reduce neuropathic pain much, but paroxetine we can use. Other thing is the citalopram. It's a very high dose, 40 milligrams. Have confirmed the efficacy for the diabetic neuropathy. But here also the side effects less compared to the tricyclic antidepressant, but other group we can use is the SNRI. The mainly the duloxetine and venlafaxine have a very good diabetic neuropathy pain relief. So the anticonvulsants mainly we are using the gabapentin gabapentin and pregabalin. So those things are very much confirmed and used so many years for the diabetic neuropathy pains, and so many randomized control trials have confirmed their efficacy for the diabetic neuropathy. But their dose is the problem, that we are using very little low dose actually. What they have recommended is 900 to 3600 milligram daily. So divided doses. So 900 at least is the minimal dose. We have to give 300 milligram 3 times daily. But we are giving very little dose of 100 octane like or 300 octane. But it is very much less compared to the recommended dose. But again, they have mentioned the tolerability of the patient. Individualized, we have to decide the dose of the drugs. And lamotrigine also they have recommended, but with very little is evidence for the neuropathic pains. Anti-arrhythmic drugs, only one drug they have recommended, bexigcitrin is the class 1B anti-arrhythmic drug. Also, they have recommended for the neuropathic pain, but there are some side effects, especially the cardiac side effects. Other agents, mainly the opioids, tramadol and oxycodone, also they have recommended for the use of diabetic neuropathy, but they have not recommended NSAID for the use of diabetic neuropathy. Other things that they have recommended is the local application of the ISDN, isosapide dinitrate spray is one thing. Other thing is capsaicin cream. It's a alkaloid in the developed from the red pepper, so it's very burning sensation. So that is also capsaicin also recommended for the diabetic neuropathy. In some guidelines, capsaicin cream is the first line treatment for the diabetic neuropathy. Other non-pharmacological measures are the acupuncture, but it is controversial. Some studies said it's not effective, but some studies it's confirmed it's effective for the diabetic neuropathy. Anyway, acupuncture also one of the option we can use. Other options are percutaneous nerve stimulation and static magnetic field therapy and electrical spinal cord stimulation. It is actually new development. That is also one method we can use for the electrical stimulation of the spinal cord for the diabetic neuropathy. So there were a few points at the end. So this is actually the regarding drugs. The pregabalin as recommended as a level 1, level A evidence for the diabetic neuropathy. And the gabapentin and sodium valproate also recommended as a level B evidence for the diabetic neuropathy. But sodium valproate is very rarely used because of the side effects. And the antidepressants, amitriptyline, venlafaxine, duloxetine, and all those things are recommended as for the diabetic neuropathy with level B evidence, but they have not recommended one over the other because all are they recommend as the same efficacy for the diabetic neuropathy. And the imipramine, fluoxetine are the insufficient evidence to support or refute the use of dispramine, imipramine, or fluoxetine are very little evidence to support for the use of diabetic neuropathy. And the other pharmacological agent, as we have described, capsaicin cream or ISDN spray, they have a level B evidence. And the lidoderm patch, it is again like lidocaine patch we are using for the peripheral diabetic neuropathy. There is a level C evidence. And dextromethorphan, morphine sulfate, tramadol also recommended for the diabetic neuropathy with little evidence. But as we have using very much for the vitamins like B12 and the thiamine, alpha lipoic acid, all these things are responsible for the pathological process, especially the alpha lipoic acid. They will try to reverse the diabetic neuropathy, but still those things are under research level, under developmental level. So none of the drugs were recommended to reverse the diabetic neuropathy still. Still we are doing the symptomatic management. So non-pharmacological monitoring as tends the transcutaneous electrical nerve stimulation and the acupuncture. So this is the summary. So the drugs, as I mentioned previously, so these are the drugs they have recommended and these are the drugs they have not recommended. Only thing is these doses, they have recommended is a little bit of high doses. So the take-home messages are the diabetic neuropathy occurs in about 55% of patients with diabetic mellitus, 55 to 60% of patients with diabetic. And the metabolic and vascular factors are the implicated in the pathogenesis. And the most common type of distal symmetrical sensory motor polyneuropathy is the most common type. And the exclusion of other non-diabetic causes also is very important. And stabilize the glycemic control, and stability of the glycemic control is one of the main thing for the management of diabetic neuropathy. And the drugs targeting the pathogenetic process are still under development and may be available in near future. So that's all in my presentation. So the two MCQs that I have given in the early. So the primary goal of diabetic neuropathy treatment is, so I think most of you have sent the answers as well. So the answer is the primary goal of diabetic neuropathy treatment is the completely reverse the nerve damage. No, it is not possible. So the manage the symptoms and prevent further damage. That is the answer actually. So that is the main goal for the management of diabetic neuropathy. So the improve the circulation in the affected area. No, that is not the goal. So the perform surgery on the affected nerves. No, that is not again we are doing it very rarely. And the second one is which of the following medication is not typically used for the pain associated with diabetic neuropathy. So the duloxetine, yes, antidepressant we are using as a first line agent, and the gabapentin, pregabalin, again we are using as a first line agent. Opioids, morphine, they have recommended, but not as a first line agent with little evidence. But topical pain reliever like capsaicin cream, so they have recommended some guideline as the first line agent. So the answer is opioid like morphine. So that's all presentation. So thank you for listening. So sorry for I have taken for that 20 minutes more. So if there's any question, I'm willing to answer. Thank you. Hello?
Yes, thank you, Dr. Lakmal, for the most comprehensive presentation on diabetic neuropathy. I'm sure you had to read quite a bit to come up with all this information in the presentation. My question for you is, did you meet this patient after you prescribed your initial medication? Did you get to see him at a follow-up visit?
Yes, in the 1 week after the prescribing, I have seen him in 1 week later.
Okay. So, what was your assessment? What did you think?
Yes, but
How has he managed with your medicine?
actually the glycemic control is very good. The second fasting blood sugar he came with 110. But the improvement of the weakness or walking difficulty part is still in the same condition. But blood pressure, other things okay. We are waiting for the nerve conduction study, cardiology, and other things. Still waiting. But patient depression also little improvement, and they are more motivated. Actually, that is the main thing we have seen is they are very motivated. They have taken drugs that we have prescribed even from the outside. So, and the other thing that the wife and the family members they have cornered. So we have taken the wife separately and discussed. So those problems, most of the things, social and things, family issues were sorted. But still the clinically the weakness is there. We are waiting for the
Right.
nerve
Can
contractions.
you go back to the drug list, please, where you mentioned all the drugs
Yes.
that you have given? If anyone else has any questions, you're most welcome to ask.
Yeah, this is
Right. Now, when it comes to diabetic neuropathy, it is a condition that is very difficult to treat. So, in literature, they say patients with diabetic neuropathy, only 1 in 3 people will respond to the first line medications you mentioned, like amitriptyline, duloxetine, venlafaxine, gabapentin, and pregabalin, that kind of thing. Even that 1 in 3 person responds partially. So it's not even a full response. So it is very difficult to treat. That you have to, at the outset, in the patient education, you have to tell and explain to the patient the damage that has already been done may not be fully reversible. You have to give realistic expectations. No? So
yes.
here, patient education comes very important. And what you're trying to do is to, while you relieve the symptoms, to quite correctly how you said, to delay the progress. In this drug list, what I was concerned and I thought you might find it challenging is that you repeatedly mentioned that he's going through some financial difficulties.
Yes.
So, depend on that account, some of these medications on the list will not be available in the hospital.
Yes.
So, do you agree, or do you have
Yes,
any other options?
yeah, actually that is correct. Linagliptin, empagliflozin, even duloxetine is not available in the hospital.
Yes, yes.
That day we have discussed with the patient. So after that,
Mm.
their daughters are, then the wife has talked to them, and we think that if we have given these drugs, it's better. But later we can change these drugs, I think, for the available drugs in the hospitals.
Mm. Yes, because these are going to be long-term medication. You cannot just get it from outside for a month or two and then give up. So it has to be a long-term plan. So I was concerned about those drugs that he might have to buy from outside with the financial difficulties he has.
Yes.
And the other problem I thought was, now you said he has a history of taking alcohol for over 30 years. Is that correct?
Yes. Yes.
Yes. So with that, like you said, it can itself be a cause for the peripheral neuropathy, but then it can also cause a lot of other psychiatric illness. So his relationship with the family, his perspective that they are not taking care of him and all that may not be fully correct. So it is just like you said, you need to get a parallel history to get down a relative and see whether the social history is tallying. So we don't know whether he has some sort of psychosis or withdrawal or pre-existing depression that might have come from his substance abuse.
Yes.
So although the family are trying to help him, he may not perceive it that way. So it's very important, and what you did was quite correct, that you got down the family to discuss these things.
Yes.
So those were my thoughts on what you presented. And the other thing is the first line medication, like you said, the larger doses on recommendations are actually studies done on people in Europe and other countries who are fairly big made than our Asian people. So those large doses may not be tolerable to our people. So we have to go by the patient's side effects and tolerability to decide on a tailor-made dose for that particular patient. And there is this study, a trial called Option Diabetes, where they tried all these first-line medications, and they found all these first-line medications you mentioned for diabetic neuropathy are equally effective. Nothing superior to the other. So you can start with anything, but then there is this problem of side effects. So you can always instead of going for monotherapy, do a combination like gabapentin and venlafaxine, if affordable, so that at lesser doses they will get more satisfactory response, and also at the same time the side effects will also be less. So that is one option you can try. That is all actually I want to add. If anyone has anything to ask. In the absence of any other questions, then we can wind up, isn't it?
Yes. Thank you very much for all the participants and Dr. Fasana, acting consultant, family physician in Best Hospital, Parudura. Thank you very much.
Good job, Dr. Lakmal. Thank you very much for all of you who have participated despite the late time. Have a good night.
Good night.
Good night.
Good night.
Thank
Thank you,
you.
Lakmal.
Thank you. Good night.